Hello, friends. My name is Kiran Kumbhar, and welcome to TIF Talkies by the India Forum. Today, in this episode, we have Aashish Gupta, who is a sociologist and demographer, and a Marie Skłodowska-Curie Fellow at Oxford University. And the general topic for today is metrics and statistics and numbers in public health and demography. Ashish is one of the best persons to talk about these topics with. So let's hear a little bit from him about his professional trajectory. Ashish, welcome to the TIF Talkies podcast. And just like, can you say a little bit about yourself and how you've reached where you are right now?
Thank you. Thank you so much, Kiran. It is very nice to talk to you. And for the India Forum publication, I really enjoy reading. It's a remarkable publication, and I'm very glad to be able to participate in this conversation with you. Your work also has been very helpful for me in thinking about my own work. So very briefly, I'm a demographer and sociologist. As you said, I'm kind of an interdisciplinary social scientist, mostly working on topics of health, social inequality, demography in India. I also do a bit of work on environment and health. I have this background in development studies. That's what I did my BA and MA in. I studied in IIT Madras, but I have a PhD. I have a MA in development studies, so that also shaped me in thinking about the role of the sciences and the role of the social sciences and humanities in general. I'd say the thing that shapes most of my work is the fact that I've done a lot of field work particularly in rural India. And so every summer, Georges and Ritika Khera used to organize these summer surveys. These were small scale studies, mostly on social security programs in different parts of India. And so through this fieldwork, I've lived in almost all regions of in rural India, and I've spent time. I've spent time often in surveys. We used to spend the time in night in these villages. Also, so I think what happened was that I started getting this good comparative sense of society and governance in India in lots of different places. And slowly, I think what also happened was that I became interested in health. I definitely saw it as one of the neglected social domains in Indian public discussions, in public policy. It continues to this day. But I think in the early 2000s, John had this neat study. What he did was he looked at op-eds published in the Hindu for 6 months. And this was where the Hindu has always been a progressive newspaper, right? But and even then, in this progressive newspaper, he found very few op-eds on health. And I think despite the COVID-19 pandemic, this health crisis that we face, we are not much better off than that. And so I got interested in demography, I think largely because it's very connected to social sciences. And so what happens in the US is that public health departments tend to be what is called quote unquote soft money, which means that they're primarily funded by grants, and so people are chasing grants. So it's actually not a very nice place to be in. And since demography was a social science, I was very interested in that. I was also interested in demography because it cared about health per se, not for instrumental reasons. Health has an intrinsic demography, mortality and health have an intrinsic value for the discipline. Um, Still, I think I'm fairly unique among demographers in doing a lot of fieldwork and collecting my own data. Though I've done a lot with secondary survey and census data also, which is the bread and butter of demography.
I like that mention of demography as like giving some intrinsic value to human health. So can you add a little bit more on just demography as a discipline and what do demographers do? And like you are doing something, but I'm sure like there's like this whole legacy of what demographers in India have been doing for the like post-independence period. If there's anything that you can enlighten us about
Yeah, no, thanks. This is a great question. So demography is very much a discipline, but it is also a subdiscipline and sometimes what is called an interdiscipline in that it informs other disciplines in minor ways. So like formally, one definition that I like is by Joseph A. McFalls Jr. It is defined as the study of human populations. And that's like really broad, right? Then everything is demography, all social sciences are demography in some ways. But in particular, I think demography cares about the size, composition, distribution, and causes and consequences of change of characteristics in a population, right? So as a discipline, if three things can change a population, you can either get born, so births, you can either die or deaths, and you can migrate from one place to another, so migration. So these are really the sub-disciplines within demography, and so you would often find demographers who focus on fertility or mortality or migration. Oftentimes people will work on a combination of the two um, as well, right? There's also a concern with social issues or social problems as they are conceptualized. So pretty much in the past, definitely in the 50s and 60s, but even before that, as well as after that, there was this concern with population growth. And especially, and this is true both globally and in India. The pendulum has swung a bit with now a concern for very low fertility, especially in richer parts of the world and with aging populations. And so that's one thing that demographers focus a lot on. One thing that I think is a nice contribution of the discipline is that it is a very empirical discipline. So if you see the big surveys that happen, the National Family Health Survey in India, and parallel surveys, which are called demographic and health surveys, demographers had a lot of role in designing and making sure that these surveys happen. I mean, the demographic and health survey program is sort of one of the, actually the biggest survey program across the world. In India, the last NFHS visited more than 600,000 households, right? So it's not a small enterprise, and think about the amount of social science that happens because of these surveys, as well as how much it contributes to public discussions. There's also, I think the demographers have also had a central role at thinking about what it means, how do we evaluate social progress. So if you think about the Human Development Index, a third of the component is life expectancy in the Human Development Index. That's some like life expectancy comes from the discipline of demography. So the discipline is very much at the center of measuring well-being and cares a lot about that. And then I think people don't care just about overall life expectancy or overall well-being, but about inequalities. There are other things that contribute to demographic phenomenon, such as cohabitation, families, and so on. And so people care about those aspects. In India, in addition to fertility, particularly quote unquote high fertility and reducing fertility, there's a long-standing concern with sex ratios, both at birth and at the population level, partly because of discrimination against girls and women, and sex ratios as a manifestation of that. So demographers have contributed a lot to our knowledge about the dynamics of sex ratios at birth in India. I should say that as a discipline, it cares a lot about good description and data quality, which is very much what my work also is aligned to.
Now I'd like to kind of move a little bit to some more kind of details about how we do metrics. So yeah, let's try and explore some examples of statistics that we see commonly employed in like everyday language. For example, this observation of like XYZ being in quotes more likely to cause ill health or disease or death. So can you take us through some of the major pathways through which researchers come to such conclusions? And maybe you can tell us more about your own research in like you found something which is more likely to cause ill health.
Yeah, no, this is a great question. And I think about this often. So I think I should start by saying that when we have data on health or other things, the first thing that we do are basic summaries, right? Uh, so there are lots of things that we're interested in for both instrumental as well as intrinsic reasons, right? So, for instance, we are interested in the size of the population, and we're also interested in the size of the population by social groups, such as what proportion of India belongs to scheduled tribes, what proportion belong to scheduled castes. There's a greater demand right now for understanding what proportion of India belongs to other backward classes, this middle caste group that face marginalization in India, right? And as we've seen, there is a demand for this caste census because people are interested in both the overall population, but also seeing how some groups are doing vis-a-vis others, right? So the first motivation for understanding why groups differ or why XYZ is more likely to cause ill health or disease is first observing these differences in the population itself, right? So I have an example. So we are interested. So for instance, lots of people in India use unclean fuels for cooking. So these are fuels such as biomass, wood, and so on, agricultural produce to cook their daily meals, right? And then you can very well imagine, because these fuels cause pollution and they're more polluting than, say, the use of electricity or even natural gas, LPG, for cooking. Then there may be some harms associated with using such fuels. And so we also know, because of gender inequality in India, it's women who are doing most of the household cooking, right? So you would think that women, because they are doing most of the cooking, they would have greater likelihood to because they're more exposed to cooking, they're more exposed to pollution from these fuels than men. They would be more likely to have, or say, lung health, for instance, right? Um, and then what happened was, then these surveys happened and they measured lung function or other measures of respiratory health, and they didn't find a difference in male and female lung health. So we had a puzzle in front of us, right? We expect something to happen based on how we think about how the world works, but it turns out that's not what's happening. Um, However, there has also been this idea within, especially this literature on pollution, is that smoke from solid fuels doesn't just remain in the kitchen, right? It rises up, it affects everyone, children, and sometimes even men. So this is the idea of what is called an externality, right? So we think we know about smoking externalities of secondhand smoke. It turns out for solid fuels, pollution is so bad that entire neighborhoods can get affected by solid fuel smoke, even if um, people themselves are not using these fuels in their own kitchen, or even men who are not cooking directly can get affected. So one of my papers was this comparison of externality, was this documentation of externalities of solid fuel use. And so here we were comparing villages where most people used clean fuels with villages where most people were using solid fuels, right? And so when you compare, these two differences emerge in lung health. But when you compare within villages where almost everyone, where even half so if you compare within villages where some people are using solid fuels and some people are not using solid fuels, there's not a lot of within village difference in lung health, right? Suggesting that even of people who are not even people who are not using solid fuels themselves, their lung health is quite badly affected.
Yeah, I think that makes sense, and like that's a good kind of way to think about how to interpret a lot of the observations and findings in this kind of research. Um, and so to build upon that, now let's say on the one hand, we know things like alcohol and air pollution. These are like significant risk factors for ill health and death. And then there are observations that living in a particular neighborhood, exactly just like you mentioned now, that if people live in a village where there is a lot of solid fuel use, so that kind of thing, through research, we have found that that stuff can also have ill effects on health. Um, Now let's try to move on from these kinds of like factors, risk factors, and try to think of bringing in the complexity of human societies itself. Um, like, for example, the complexities of living in particular social, economic, and political conditions. And I think you have done some research to that or in that field. Our listeners obviously are probably aware of how the COVID pandemic has provided some striking examples of the importance of such broader factors. Um, yeah, but as a scholar steeped deeply in these topics, can you tell us more about how researchers study like such a broad factor as like a caste community, or how like race affects healthcare? Um, and again, if I'm sure like you can use some examples from your own research for this question also.
Yeah, I think this is a great question. So I think oftentimes what in the public health disciplines or broadly in epidemiology, we are trying to replicate a randomized controlled trial, right? So when you're trying to replicate a randomized controlled trial, what you do is you randomly assign some treatment to a particular group, and then you try to see differences, right? But there are so many things that are in our society that we cannot randomly assign to groups, right? So gender is one of them, for instance. The social group you're born in, whether you're born in a high caste household or a marginalized caste household, this is not something that that as researchers we don't have the ability to randomly allocate. And also you can also imagine the kind of harms that we will create if we had this ability, right? So and yet we know that these things can affect well-being more generally, but also health. And there are various mechanisms through which these um, these conditions can affect health. So there is an important paper which calls social which by Link and Phelan, which calls these conditions as fundamental causes of health and disease. So what Link and Phelan are looking at, they're mostly looking at U.S. society, and they say that, okay, fine, you can look at very early on and you can look at now. And it turns out that still people who are marginalized or have lower social position in society, have lower access to resources, have worse health on average. It turns out there have been massive changes in society, and but still that fact continues, right? So that's why they are talking about this as a fundamental cause, in which even with new technologies, massive churning, even when the things people die of have changed, social conditions remain important, right? So what is it about social conditions that they are so persistent? And so some of this work that we did in India actually uses data from the National Family Health Survey. So the National Family Health Survey for children under 5, it has a very well used methodology to estimate mortality rates. What it does is that it asks women in reproductive ages age 15 to 49, all the children that they have ever had and whether their children survive. If their children didn't survive, they ask the age at death of those children, right? And for adults, or for everybody else, the National Family Health Surveys ask this question: has there been any member of your family from a member of the household? They ask, has there been any member of your family who died in the last couple of years, right? So using this data, what we can do is we can estimate age-specific mortality rates. And when you do age-specific mortality rates, then you can also do life expectancies. It turns out the NFHS has also asks data on household wealth and on the caste and religion of households and individuals, right? And so you combining this data, we did one of the first exercises of life expectancy by social group in India. This research found very much like race disparities in the United States. This research in India found large disparities in life expectancy. And they were also persistent. So we could see them in the early 1990s and we could see them in the mid 2010s also. Right. So in this period, 25 years, not much has changed. And so think about the amount of growth that the Indian economy has had in these past years. And despite that, we found persistent disparities in life expectancy. We are doing some new work on what happened with these disparities in the context of the COVID-19 pandemic. And so we have some data from the National Family Health Survey for 2020. It turns out that marginalized social groups in India actually faced deeper declines in life expectancy than for higher caste or less marginalized social groups. The group that faced the biggest declines were actually Muslims. And this is actually really troubling and sobering, but it is also consistent with other things we know about what is happening in Indian society. So in 2020, Muslim life expectancy was basically similar to scheduled caste life expectancy and scheduled tribe life expectancy. And so in 2020, these three were the most marginalized social groups in Indian society. Oftentimes, when we do this research, we face a lot of, particularly from privileged members of Indian society. So, for instance, we face a lot of pushback against this research. So, you had this question about how can we think about biases and limitations of research, right? And I'll give you an example. The first time when we published this paper on persistent disparities in life expectancy in India, we got this, oh, but this is because of genetics. Oh, but this is because of their behaviors. These people drink a lot and then they die. So actually, the disparities are for both adults and children. They are for both men and women. And so we know in Indian society, women don't drink that much. We also know that actually Muslims don't drink that much, right? And even they have worse life expectancy. So actually that cannot explain it. Similarly, I think for genetics, we know there's some truth to this. So for instance, we know that Adivasis are more likely to have sickle cell anemia, right? So it's partly a genetic disease, but the amount of sickle cell anemia is just not enough to explain the very, really large disparity between high castes and Adivasis, right? And so on. We know that actually, in terms of genetics, the Indian population is fairly similar in terms of the diseases, in terms of the things that cause ill health, and so on. So, I think the usual way we think about people are thinking in the usual way we think about biases, right? When you say A and B go together, people think, oh, is there a C that can explain it? It turns out that we have thought, and in general, we need to think very carefully about these other factors that can explain the difference, right? In one of our papers, we did this, we know that marginalized groups in India are also poorer, right? So in one of our papers, we did this accounting of can disparities in economic status explain the social disparities that we see, and it turns out that actually economic disparities cannot explain the social disparities that we see, which points to the role of discrimination, violence, marginalization inequality in resources made available to different social groups, and so on. Um, the the there's there's a lot of research that can go on exactly why marginalized groups face these disparities in life expectancy. And some of this we're doing, and we know other people who are also interested in answering these questions. On the other hand, the basic description is also quite important for public discussion. Right. So, for instance, the fact that these disparities are persistent and not explained by economic status points to the fact that you cannot correct it by just focusing on economic growth or on transferring, say, just money. Like, it's not just about economic wealth that happens. There's something about society and discrimination and social factors that needs to change, right? And we know that conversation is very limited in Indian public discussion. That conversation still is just barely beginning to happen in Indian society. We also know that, for instance, when we saw this Muslim life expectancy becoming really very similar to SC and ST life expectancy in 2020, and we know that this is consistent with the stereotyping and marginalization of Muslims that have happened in the past few years, which have intensified. Muslims always used to be marginalized in Indian society, but this marginalization has increased with the rise of Hindu nationalism, right? So again, we have something that is consistent with broad patterns in society. I should say that, as we say, this is really quite like when you do descriptive life expectancy work, this is really broad scale, right? And it's possible to think of it as at a much smaller scale. So we're using national data in this large scale survey. And so you can both think of a different scale, but you can also think of different methodologies, right? So whatever I'm saying is not news to anybody who comes from a marginalized background, right? Their answer is, yeah, duh, of course, this would be the case. And so what we're doing with this work is just quantifying what a lot of people just believe to be a social truth already. Yeah.
No, yeah, thank you. I mean, I think I would also like to add here that as far as I know, for like a long time, such research was never done. I think at least in like the academic disciplines in India, there was no one who was going to say, oh yeah, let's look at differences in well-being, in health, in life expectancy based on caste status or based on religious status. And so I think this is important. And thank you so much for enlightening us about this work and also making that important point that you also followed up with research trying to explore if economic factors could explain those differences, and that research showed that no, economic factors are alone not responsible. And so we have to like kind of be face to face with the fact that it's the social status and it's the social kind of background which is responsible for these differences and disparities.
Yeah, and I think what happens is that and I think this is an important point also, because this is the point we think is the most obvious one, and yet we see an inability in wider public discussions for many people to just see this basic point, right? They want to think of all the other factors apart from, well, caste is responsible for this. No, caste, they want to say, no, caste is not responsible. Everything else could be responsible. And so they come up with multiple things. And I think this is the harm with a public discussion that is basically dominated by upper caste people who are not willing to see caste, right? And then I think that also partly explains why people don't ask these questions in academic circles. We know that academia also, both in whether it is Indians in Indian academia or Indians outside Indian academia, they tend to be dominated by people from particular caste backgrounds. And then that, uh, uh, I should say that it's not that people from who are privileged background cannot ask these questions, right? But there has to be a willingness to ask these questions.
Exactly, yeah. So thank you for that. And yeah, I mean, I think as we come like close to the end of the interview, there's a few kind of consolidatory ideas that I would like to discuss. Mainly, I'm sure like a lot of our listeners and you are aware of this old saying about data and statistics, that we can make them tell us virtually whatever we want them to tell us, right? So yeah, that's just like what statistics means for a lot of people. And I was wondering if you have any examples that you have come across that you have seen other researchers making conclusions and assertions using some forms of data, but you know about those forms of data and you probably think that, oh, that conclusion makes little sense or no sense. Is there like some example that you have? Or...
Yeah, there are so many examples of this, but I think it's useful for us to focus on examples that may be consequential. So one thing, for instance, is this is India's in the national government in India. They keep on arguing that India did very well on responding to the COVID-19 pandemic, right? And this is entirely based on data on cases and deaths from COVID-19. These are officially recorded cases and deaths of COVID-19. We know from a lot of data now that actually the surveillance of the pandemic was extremely patchy in India. It mostly concentrated on urban areas, even in urban areas. The poor were left out of surveillance. A lot of people died without their deaths getting captured by pandemic surveillance, right? And so you just cannot depend on this data to make any inferences about how the pandemic unfolded in India, right? And this is not just the government. I think newspapers, or if you look at when the pandemic was at its peak, every day you would have these many cases, these many deaths, and so on, right? Some news channels used to have a ticker about this. I so it is really it was for me really remarkable to see so much attention to such bad data. Um, there are other examples of this. There is research saying that actually the COVID-19 pandemic in India wasn't that unequal and it was an equalizer. It turns out that this research comes from very biased data sources that are from a sample survey that actually mostly concentrates on the rich. And so poor are really underrepresented in the sample. And so, of course, they don't find massive inequalities in COVID-19. There's a lot of, before the COVID-19 pandemic, you may recall that the government had this Swachh Bharat Abhiyan. So the plan was to make India open defecation free, right? And so you can visit a village and then you will realize that India is not open defecation free. The government claimed that India became open defecation free by 2nd October 2019. And this was on the basis of the number of toilets it had constructed and also quote unquote independent surveys that measured open defecation. There were lots of problems with both the survey and this administrative data on the number of toilets that have been constructed, right? So one thing is that owning a toilet is not the same as using it. The survey the survey that the government used measured open defecation at the household level. So it asked households, so do most people in your household use the toilet or not? And we know that open defecation is not a household behavior, it's an individual behavior, right? So it's just a very basic thing of asking the question individually is still not done by most surveys on this topic in India. The final thing I think is that there had been a lot of coercion in terms of forcing people or in terms of preventing people from accessing their entitlements if they did not have a toilet, right? And so when there is a lot of coercion that is happening, you can recognize that survey questions will not work well at all, right? Because people will think that actually you're from the government and they worry about things that are very meager but are quite important for them, such as their rations from the public distribution shop, right? Um, um, and so you would not get really good responses on these questions, even in a survey setting, right? But all of that was lost, and the government still believes that India is open defecation free. And so what happened after that was the government had a program to subsidize construction of toilets for households. So it used to give 12,000 rupees if you constructed a toilet. That program ended in 2019, right? And then after that, that program is not has we haven't seen that program at all. Uh, and so one really worries that that actually open defecation in India is actually quite high, and as the older toilets that the government constructed fall apart, it will actually increase in the future, right? But it's sort of an issue that has fallen out of public discussions, mostly because the government said that okay, fine, we are done, we achieved our goal, and that's it. That's the end of it, right? Um, and so you see, you see these kinds of manipulative data all the time, and it's so I think people have the sense that you can tweak data into whatever. I think what people should also start focusing on are what is the data and is it reliable in the first instance before you start doing analysis with that, right? And so to me, oftentimes, good data is a check in that you believe something, and then if you have decent data, then you can check whether your beliefs are true or not, right? Or you observe. So, for instance, oftentimes what would happen is I would observe something in fieldwork, and then I would check: is this true in this area, or is this true nationally? And that way there is a very important conversation on data quality that I think more of us should be invested in. It's at least those of us in the social sciences and who care about these things.
Yeah, I think that's a good point about data quality. And yeah, I think it's so important because when I mean, the other point you made about open defecation, because obviously a lot of people do know, they see around them that open defecation has not gone away. But maybe they will say, oh yeah, like the government is crazy. So they just like want credit for themselves. But I think what I get from what you said is that it's not just that, but they are actually using what can appear at first sight to be a very well done survey and study. And they are saying that India is open defecation free, not just out of any whim and fancy, but at least on the face of it, trying to support it through data. And that's an important point to remember, that like it's not just happening arbitrarily. There's like a systematic kind of use of numbers in this also.
Yeah, that's very important that it's a willful use of it's as you said, systematic use of bad data.
Yeah, so that's wonderful. Just some final kind of thoughts and questions. So you've been playing with numbers on health for many years, and I think through several different kinds of global and national socio-political contexts. I think you said that you probably began doing a lot of this in the early 2000s or mid 2000s, right? So I was wondering if you have anything to say on how your own understanding of your work and of your methodologies has changed since you first began working. And let's say you're asked for general advice by a master's student who wants to work in epidemiology or demography or some related field. what would be your advice to them?
Yeah, no, I don't have a lot of advice. I think young people are quite interested in these fields for good reason. One thing that I think in my personal life I learned a lot from, as I said, is from field work and just having a sense of what is happening, even for your own questions, right? So even if you are very good at data analysis, you could obviously visit some places and check on what is happening. The second thing is actually a lot of good ideas will come from general exposure to people's lives, and spending time with them, right? So a lot of good ideas actually come from that. And this is, so I'll give you an example. I talked about this solid fuel use being an externality. And so it turned out that actually if you're in a village in rural India in the evening, let's say you are in Bihar or UP, right? You can see smoke all over. And so Bihar, villages in UP and Bihar tend to be about, say, 1,000 households each village, right? So when hundreds of households are cooking with solid fuel use, it does tend to build up quite a lot of smoke. You also see it in satellite data. So if you look at satellite data on air pollution across North India, actually starting from Punjab in Pakistan to Bangladesh, you see this entire belt is very polluted, right? And so I think the second point is actually when we are doing research or is to think about the things that are consistent with one source and the things that are contradictory. When things are contradictory, if you find an answer, that could be a contribution. When things are consistent, they're also quite interesting on its own. A lot of work that I have done is getting exposed to these puzzles, that I see something in one place and not something in another place. We see the government claiming it's open defecation free, but actually when you see villages, they're not open defecation free. So how did the government data got it so wrong? And so you ask these questions, and then you find some sort of answers, even if and so that I think has been quite a useful process for me. There's this a lot of information is actually contained in the reports, right? And so you don't need to be a whiz at data analysis or skill. You don't need a lot of skill. You just need to download these quote unquote boring reports and look at them. And if you're asking questions, you can find a lot of insight just by looking at that. But also, I think there are oftentimes it's quite helpful to read field accounts or field work accounts or ethnographic work by other people. And so there are oftentimes we're exposed to ethnographic fieldwork that is current, but it's actually quite helpful to read older ethnographic work which people are not paying attention to, especially on the topics that you are interested in. Yeah, I think those are some ideas that I have.
No, thank you. That's perfect. So, I mean, yeah, I think just to summarize what you said, like look around, be attentive to the world around you, give a lot of importance to lived experiences and read a lot. So, I mean, I think that's a good point to like read stuff that has been written in the past, which we tend to ignore, including ethnographic stuff. Yeah, thanks a lot, Aashish Gupta. And it was wonderful to have you here on the India Forum Talkies.
Thank you so much for having me. Thank you.